I'm going to talk about new off-label indications for TAVI. Since 2002, when the first in men using doing TAVI procedure was performed by Alain Cribier, TAVI has emerged as a good alternative to surgical AVR in patients with severe aortic stenosis who are in high risk or inoperable. Many patients with other valve pathologies are also at high surgical risk, and we heard about the mitral valve, and they also may benefit from transcatheter valve implantation, and that's the topic of my talk. I'm going to talk about two new transcatheter valve implantation for off-label indication, the aortic regurgitation and failed bioprosthetic valves. TAVI was developed for aortic stenosis patient, but the patho-anatomical issue of aortic stenosis is a little bit different from aortic regurgitation. In aortic stenosis, the valve will be more thickened and more calcified than in aortic regurgitation. The annular size is usually larger in aortic regurgitation, and there's also aortic root dilatation, more prominent in aortic regurgitation than in aortic stenosis. Currently, we are using two types of valves, the Edwards-Sapien valve and the CoreValve valve, and when we use those valves in both off-label indication that I was mentioning, we have to remember that they are completely different, not only from the point of view of that one is balloon expandable and the other is self-expandable, but also on which part of the valve, the native valve, they are anchored, and what do we need in order to position them in the right way. The Edwards valve, for instance, is completely dependent on the presence of annular calcification and calcification symmetry and annular sizing, and it's independent of the aortic root size. I'm showing you what's the importance of annular calcification. This is a implantation of one of the first cases with aortic insufficiency that we used. We decided to use the Edwards valve, and we implanted the valve, and it was only a few seconds later the valve simply jumped and was outside of its original location, and we had to deliver a different valve. This time we picked the CoreValve, which was implanted successfully. So we concluded from this experience that regarding if you want to treat aortic regurgitation patient, the use of the Edwards system is possible only if it's combined calcific degenerative of the aortic stenosis and regurgitation, but not in pure aortic regurgitation with no calcification. The CoreValve is more suitable for this pathology since it's not dependent on the calcification of the valve and the fixation in the annulus and the ascending aorta. So, based on our experience and other experience, we were part of a registry that initiated and conducted using TAVI, looked at TAVI using CoreValve for pure native aortic regurgitation. The aim was to evaluate the off-label treatment of TAVI for pure native aortic regurgitation using the CoreValve system only in patients with prohibitive surgical risk. This registry information was published recently in the Journal of the American Journal of Cardiology. 43 patients enrolled in this registry from 14 centers, from most of them Europe, but also from Israel. The mean age of the patient was 75, almost half female, a little bit more than half. The mean logistic Euroscore was 27%, and the STS score about 10%, and all patients were in NYHA class 3 or 4. The pathology was degenerative in 28 patients out of those 40, and the rest were different type of pathologies, post-endocarditis, aneurysm, and other pathologies. This is one of the most important things that we learned. In 60% of the patient, there was completely absent calcification. Annular calcification was completely absent. And in the other 40%, there was some calcification, but the majority of them, in the majority of them, it was only a mild, and only in about 10%, there was moderate or severe calcification. So most of the patients are without calcification or only mild calcification. We use the same way we use TAVI in severe aortic stenosis patient. Most of the patient, we use the transfemoral approach, some subclavian approach, direct aortic, and even carotid approach. Successful implantation achieved in 42 out of the 43 patients, 97.7%. One patient was referred immediately to heart surgery and valve replacement. Second valve was required in 18% of the patient, 8 patients, and the paravalvular leak was one or less in 80% of the patient, and 3 or more in less than 5% of the patient. If we talked about success of 97, but if we look at, if we evaluate success according to the VARC definition, then the procedural success was 77% of the patients. In all 8 patients who required second valve, we noticed that there's completely absence of calcification, both on CT or echo that was done, and this was significant. And the reason for the second valve in this situation is, one, the difficulty in positioning the valve, since you don't have a marker to position the valve, so operators use different type of techniques to mark the location where the valve need to be implanted. For instance, one technique was a double pigtail technique, where you put 2 pigtails in the valve in the different cusp, and you use it as a marker. And the other problem of lack of calcification is the anchoring of this valve in the annulus. So even though we use the CoreValve, and you don't need to do pacing when you implant CoreValve, many centers use pacing, rapid pacing, in order to prevent motion of the valve until you get full mounting of the valve, both in the annular position and the aortic root position. So what about the outcome? The 30-day mortality was 9%, 2.3% cardiovascular. Stroke, 30-day stroke was 4.7%. And the 1-year mortality was 21%, half due to cardiovascular reason. Regarding NYHA functional class, almost all patients improved significantly in 30 days. So our conclusion from this aortic regurgitation registry, that aortic insufficiency is a relevant indication for TAVI in high-risk patients, but requires special technical consideration. I mentioned some of them. In absence of annular calcification, CoreValve is probably the preferred, or I should say maybe currently the only valve that can be used due to fixation of the frame in the ascending aorta, and not only on the annulus. But we have to remember that there are still higher incidence of requiring valve-in-valve, and new devices need to be developed. Few things about valve-in-valve procedures. Valve-in-valve procedures are in bioprosthetic valve. that are increasingly used in the last years. We have to remember that bioprosthetic valve commonly fail within 10 to 15 years, and transcatheter valve implantation is a possible indication. Most of the information we have regarding valve-in-valve is from the registry that was published in Circulation 2012 by Dvir and Kornowski from Israel, and many centers in Europe as well as in Israel participated in this. The registry included 460 patients, most of them with stenosis, but a lot with combined stenosis and regurgitation, and also pure regurgitation. The demographic was similar to the registry of the aortic stenosis patient, and the baseline echocardiographic parameters are on this screen also correspond to if you have stenosis, regurgitation, or combined. We see in this registry that both valves are used to treat those pathology in the bioprosthetic valve, more regurgitation in the used CoreValve, and in the stenosis pathology, the Annular was used more often. And what about the results? We can see here that regarding the procedure, pre-implantation valvuloplasty used in the stenosis more obviously than the regurgitation. Malar position was a little bit more in the regurgitation. Second valve, similar in two procedures. And there's one thing that we have to pay attention is the clinically evident coronary occlusion, which was more in the stenotic patient, probably due to one, use of Edward valve, and second reason is the tissue growth, and this can be decreased significantly if you know the anatomy, if you know the distance of the CoreValve of the coronary artery from the annulus, and if you maybe pick a different valve to do it. Success was obvious. You get less stenosis when you put the new valve with less gradient, and you get less regurgitation in the regurgitant patient, and the EF remain the same. This is very important information from this registry, and this information teaches us actually about the different type of valve when we use them in different type of patient and different type of prosthetic valve. The smallest the valve with the smallest inner diameter, you have, if you implant Edwards Sapien, you have more problem because you have more a gradient, and whereas with the CoreValve, it's relatively no much different in small or larger valve, maybe due to the smallest profile in the annular positioning, and the most important is that the CoreValve actually is a supraannular implantation, whereas the Edwards Sapien, it's a true annular implantation, and with the profile you get more stenosis. Stenosis is not good because it's it's an independent predictor of mortality and complication, and you can see it from this analysis. The success or whatever you achieved persist for more than the 30 days that was evaluated, but also to 12 months. The gradient remained lower, the regurgitation didn't change, and the functional class the same. Here's the 30-day clinical result regarding mortality. Patient with stenosis die more than patient with regurgitation or combined patient, and we have to keep it in mind. And this is the Kaplan-Meier presenting the same information just mentioned now. When the strongest independent predictor of 1 year mortality post-valve-in-valve was the baseline bioprosthetic stenosis. And this is also need to be remembered, especially, but to have in mind that in most patients, the valve that was used was Edward in this situation. So in conclusion, valve-in-valve procedure, although feasible, is technically demanding, including several safety concerns. The technique is clinically effective, and most patients with 1 year result comparable with other TAVI cohorts. The baseline prosthetic bioprosthetic stenosis is the strongest predictor for both elevated post-procedural gradient and 1 year mortality, and the possible impact of moderately elevated gradient on valve durability should be examined in the long run. Only 1 minute to talk about valve-in-valve in the mitral valve position. In the same registry, there were 91 patients, most of them valve in mitral valve, some in mitral ring. Demographic almost identical to the other group of the aortic stenosis. Baseline echo parameters are also correspond to the fact that some had regurgitation, some stenosis, and some combined. The valve that was used in this pathology was only the Sapien device. In 60%, the Sapien XT device was used, and you can see that the valve different from 23, 26, and 29, majority 26 millimeter valve. The procedure performed, since it was in the majority of cases 85% transapical approach, it was under general anesthesia with also TE guidance. Results post-procedure were good, with mitral valve area increased. Gradient was a little bit higher than what we like to have, and this is again the nature of the position of this valve inside the valve and the existence of stenosis. And you can see here, similar to what we have seen with the aortic valve, if the valve that you implanted, the Edwards valve is smaller, then you get a higher gradient, and the bigger the valve, the smaller the gradient that you get. What about outcome? In those 91 patients, all-cause death was close to 12%, most of them cardiovascular, stroke was 1%, and other complications are listed, not different from complications that we see in TAVI, usual TAVI procedure. But the patient in 30 days, looking at the NYHA class, they improve significantly. And this is the Kaplan-Meier after 37 months. You see that the 12 months survival rate is almost 75%. So to conclude, mitral valve valve using Edwards Sapien device performed very high risk in high-risk patients, were clinically effective. 1 year result comparable to native aortic valve. Safety and efficacy concern include relatively high in-hospital mortality and elevated post-procedural gradient need to be remembered. So that my take-home message, this is my last slide, that off-label use of transcatheter valve implantation is an increasing clinical reality. The indication for transcatheter valve implantation need to be rediscussed and may be widened to include treatment of these additional valvular pathologies in highly selected no-option patient. And maybe the most important take-home message is that new devices more suitable for the new indication need to be developed before moving to moderate or low-risk patient. Thank you.